for our webinar, Women, Heart Disease, and Medical Devices, What Women Need to Know. This is Eva Maciejewski, the Manager of Communications at Marketing at WomenHeart. And next to me, I have Emily Schwartz, our Senior Associate for Public and Patient Programs. And today, you will hear from Dr. Annabelle Volgman, a member of our Scientific Advisory Council and Medical Director of the Rush Heart Center for Women at Rush University Medical Center in Chicago. She will take questions after her presentation, and I will moderate the Q&A, and I will give you instructions at that point in time about how to submit your questions. So without further ado, it is my pleasure to turn it over to Dr. Volgman.
Hello, everyone. Thank you so much for listening in. I'm happy to present today's program. We've been working on this for the last few months, and I'm very excited that we're presenting this today for all the women out there who are undergoing procedures. This could answer your questions for all the women who have devices. This hopefully will answer some of your questions as well and open it up for the question and answer. As a background, I'm an electrophysiologist, so I did put in pacemakers and defibrillators, and know that the support was so important among each other. So it's very fitting that WomenHeart is doing this program today. So I'd like to start with some background. Go ahead and change this slide. Oh, I have no conflict of interest, just to let you know. So let's start with some background. Cardiovascular disease is an umbrella term that encompasses all the diseases of the human heart, blood vessels, and strokes. And in a minute, we'll go over some of the most common heart conditions to give you some context for the medical devices to address them that are the main focus of this webinar. As you know, cardiovascular diseases place an enormous toll in the United States and around the world. It is the leading cause of death for women of all races in the United States, causing a quarter of deaths in women each year. 8 million women in the United States currently have some form of diagnosed heart disease. Next slide. As you can see from this slide, the dark reds are not a good sign. We call that southern part of the United States the stroke belt because there is a lot of heart disease and strokes in that area of the United States. As you can see, it affects women in all parts of the country, and some are worse than others. Okay, next slide, Eva. As you know, WomenHeart has been trying to let us all know this, that heart disease is not just a man's disease. There's been a misconception that heart disease is a man's disease, but in fact, more women have died from heart disease since 1984. People are gradually becoming more aware of the toll of heart disease in women, and studies have shown that more than half, or 56% of women today now recognize heart disease as the #1 killer, compared to just 1 in 3, about 30% 15 years ago. So it sounds a lot better, but it's still just a little bit more than half, and we would really like everyone to know that this is the case. We can do a lot better than that, since heart disease is something that women, their healthcare providers, and the society as a whole need to take very seriously. Younger women and minority women show overall less awareness of threats posed by heart disease, and we need to educate those parts of our women population. And unfortunately, even doctors aren't always aware of the risks. Studies have found that disparities in doctors' attitudes, testing, and treatment of women for certain cardiovascular conditions, meaning that doctors may offer tests or treatments more readily to a man than to a woman with the same risks or symptoms. So we don't want to put up with that, do we? Next slide. Here is the risk factors for everyone, and there are some specific risk factors for women that affect only women, such as birth control pills and pregnancy and early menopause, of course. Autoimmune disease is predominantly in women, but of course men can have autoimmune disease as well. But for everyone, the risk factors for heart disease, as I'm sure most of you know already, are family history, smoking, diet, physical inactivity, excessive alcohol use, obesity, high cholesterol, high blood pressure, and diabetes. We really should be paying particular attention to women who have symptoms of heart disease when women are taking birth control pills or when they're pregnant and having shortness of breath. We really need to watch out for those. Okay, next slide. Eva, I think this is your poll.
Yes. Okay, everybody, this is Eva. We have 3 poll questions in this webinar, and these go relatively quickly. I'm going to read the first poll question, and you can answer on your, once I launch the poll, you can answer on your control panel, and then I will close the poll. So the first question is, have you been diagnosed with a form of heart disease? I'm launching it now. Perfect. Thank you. Most of you have voted. I'm closing the poll. Thank you for doing that. We are not going to announce the results publicly right now, but
okay.
We may later on. Okay, and let me.
So this slide shows the different types of cardiovascular disease. As I said earlier, it encompasses many different kinds of disease, whether it's an arrhythmia or heart failure, heart attack, heart valve disease. There are many different forms of cardiovascular disease. It is not uncommon for someone with heart disease to develop more than one of these conditions as well. So not all of them require a medical device, of course, but we will go through the medical devices that have specific conditions that they need this device for. So one of the most common is arrhythmia. An arrhythmia is when the heart beats too fast or too slow or irregularly. And some arrhythmias don't require treatment, such as just a skipped beat or PVCs or PACs, and sometimes the treatment for those diseases are worse than the disease, so we don't want to needlessly put patients on drugs that they won't benefit from. And a person with an arrhythmia is more likely to go into sudden cardiac death if they have heart disease, and so we want to be able to know whether somebody has heart disease if they're having palpitations or if they're having skipped beats. And that's one of the most important things to establish, is whether the person who's complaining of arrhythmias has heart disease or not, because we would treat that very differently than somebody who has a totally normal heart. As you know, one of the worst problems or worst arrhythmia is sudden cardiac arrest, which is fatal, and most patients who have that out of the hospital are not able to be resuscitated. A very small percentage will be able to be resuscitated and make it to the hospital and make it out of the hospital alive. So that's a very serious problem, and so we really always try to identify those patients. And just another important heart disease is a heart attack, and that's when the heart doesn't get enough oxygen because the flow of blood is blocked by blood clot from a plaque, and that can lead to arrhythmias also and can actually be fatal. Women are far more likely, unfortunately, to die of a heart attack than men. Unfortunately, it's been shown recently that 42% of women who have a heart attack die within 1 year, as opposed to 24% of men. So that's really bad news. And we really have been trying hard to educate women to be more assertive about getting the right treatment when they're having a heart attack. 435,000 women each year have a heart attack in the United States. And then one last disease I want to emphasize is heart failure. And this is when the heart can no longer pump enough blood to meet the body's needs. It's just not strong enough to be able to accommodate what it needs. It can be caused by coronary heart disease, the blockages of the heart arteries. It can be caused by high blood pressure or diabetes. And each year, 320,000 new cases are diagnosed in women who have heart failure. Let's move on to the next slide. So what are the treatments? First and foremost, and we always emphasize it to our patients at the Rush Heart Center for Women, and we have a nutritionist actually that helps us take care of our women patients, is lifestyle changes. We have to emphasize that everyone should be eating heart healthy. They should be exercising. That's one of the best things they can do. And we have a picture of an older woman who is swimming. That's a great exercise for people who have knee problems or arthritic problems. They can swim as long as they're getting their heart rates up. It's a great form of decreasing their blood pressure, decreasing their cholesterol, and just making them feel better, decreasing their stress level as well. Of course, medications plays a huge role in treating women and men who have heart disease. One of the most important ones are aspirin, cholesterol medications called statins, beta blockers, and ACE inhibitors. So anyone who's had a heart attack should be on, if possible, all of those medications. There are also non-surgical procedures, which we're going to talk about in some of the later slides. So we don't always have to open up the chest to abort a heart attack or to open up a valve nowadays. We can do these non-surgical procedures that has really been much more favored by our patients so that they don't recover for so long. But in some patients, we do need to have surgery because they just have too much disease that the interventional cardiologist can't just do an angioplasty or put a stent in or open up a heart valve with a non-surgical procedure. And then the topic of this talk is the medical devices. So we will talk about pacemakers, defibrillators, valve replacements, and things like that. Okay, next slide. So I already talked about heart-healthy diet and exercise, but one of the most important things is right in the middle there, quit smoking. And hopefully none of you in the audience are still struggling with smoking, and hopefully most of you have never done it, because any history of smoking can increase your risk of not just heart disease but lung disease. Controlling stress, I can't emphasize enough how important stress we're seeing to be a big problem in causing heart disease. And one of the most important things that you can do to decrease stress is attitude, but also exercise. So learn to control your stress. All of us are under daily stress, but if you're under tremendous stress, make sure you seek help from a lot of different healthcare providers, such not only your primary care provider, but you may need counseling, therapists, psychiatrists. Don't hesitate to ask, because stress can play a big role in heart disease. And of course, manage your risk factors, lowering your blood pressure, lowering your cholesterol, and things like that. Okay, let's move on to medications. As I alluded to earlier, beta blockers. Beta blockers are an important part of medications in patients with heart disease. It's not only good for high blood pressure, it lowers the heart rate for people having arrhythmias, but it also helps the heart remodel itself when somebody has heart failure. So a very important medication for cardiologists to use. Statins, of course, are one of the best medications that patients can be on to decrease the risk of heart attacks, strokes, and deaths. So statins play a very important role in cardiovascular disease. Diuretics are actually, certain diuretics we tend to use as needed, like Lasix. A lot of patients need Lasix when they're in the hospital, but one of the most important diuretic for patients with heart failure is spironolactone. So make sure that if you have severe heart disease and you need a diuretic, that is one of the diuretics that they're using already, because it's been shown not only to be good for heart failure, but it can actually decrease your risk of arrhythmias, because it makes you retain potassium as opposed to lose potassium. And potassium is one of the most important things that we look at to prevent arrhythmias. Blood thinners and antiplatelet agents are also a very important part of our armamentarium for treating patients with heart disease, because a lot of cardiovascular disease are caused by blood clots. And so atrial fibrillation, you need blood thinners, but if you have coronary artery disease, most of you will need antiplatelet agents. So aspirin, clopidogrel, Brilinta, those newer agents that your doctor may put you on. ACE inhibitors are not only good for your blood pressure, but also very important for heart failure. It can also reduce cardiovascular deaths, and so very important. They also make you retain potassium, and that's a very important factor in treating arrhythmias, as I said already. Calcium channel blockers are used for patients with high blood pressure, for patients with arrhythmia, so another important kind of medication. And then vasodilators, if patients are having difficulty controlling their blood pressure, that is also very important. And patients with heart failure may need vasodilators like hydralazine, a very good blood pressure medication for patients with high blood pressure and heart failure. Next is non-surgical interventions. So Eva, let's move on to slide 13. So this is a very helpful treatment for a lot of our patients who are not doing well on medications alone. So if you are having a heart attack, if you are in the throes of a heart attack, you will most likely be rushed to the cath lab and have an angioplasty and stent placement. That is the best treatment at this point to treat patients who are having a heart attack. But if you're also having a lot of chest pains and you have arteries that are closing up or significantly blocked, angioplasty and stent placements are also very good treatment for you. If you have a valve disease that are really causing a lot of arrhythmias and causing a lot of symptoms, the surgeon or the interventional cardiologist can also do valve replacements, and that's one of the topics that we're going to go over later on. For arrhythmias, we can do ablations where we put in catheters inside the heart, and depending on where the arrhythmia is coming from, it could be a simple procedure that you would be cured from, such as WPW or SVT, supraventricular tachycardia. Those are 99% effective, and it doesn't take long to do. But if you have atrial fibrillation, those are not as successful. You may need more than one procedure, but they can really be extremely helpful in treating patients with atrial fibrillation. Some patients will just need an AV nodal ablation, where we actually burn the tissue that connects the upper chamber, the atria, to the ventricle, the lower chamber, but they will need a pacemaker after that. Okay, next slide. We won't forget the surgical treatments. Those are usually bypass surgery and or transplant, and then valve replacements also can be surgical treatments. Okay, next slide. Okay, so let's talk about the topic of this lecture, which is medical devices. So as you can see, there's many different kinds, and we'll go over all of these in the next few slides. So if you have a pacemaker or an ICD, those are defibrillators, or CRT, we're going to talk about all of these. These are mostly defibrillators. Those are arrhythmia devices, but then there are also devices that can replace the aortic valve, so we call those TAVR, or transcatheter aortic valve replacement, or transcatheter aortic valve implantation. They're basically the same. And then for coronary artery disease, we put stents in. And then for patients with heart failure or a bridge to heart transplant, there is what we call the VAD, or the ventricular assist device. So we're going to go over these in particular. So I think Eva is now going to take a poll.
Yes.
So go ahead, Eva.
Okay, thank you, Dr. Volgman. So our second, we have two more poll questions, this one and one that's coming right after this. Let me see. Sorry, I'm looking for my, my polls had disappeared. Okay. So our second poll question, which I will launch after I read it, has your doctor discussed surgery or cardiovascular medical devices with you? And I'm launching it now. Okay, great. Most of you have voted, and I see a split, kind of a split vote. I'm going to close this poll. Thank you so much. And then there was one final poll question. Are you currently living with a cardiovascular medical device? I'm going to launch it now. Okay, great. Most of you have voted. This one is also split down the middle. Closing this poll. Great. Thank you so much. And Dr. Volgman, back to you.
Okay. So you're probably wondering, how are these devices approved for use? There are many different kinds of manufacturers that create these devices, and it's, of course, in many different fields of cardiology. So you could have pacemaker devices that also do defibrillators and the CRT devices. And then you have these valve devices that a totally different group of manufacturers actually create. And it's really an exciting field right now because the field is just booming, and we're just starting to see more and more aortic valve replacements be done, and it's really made a huge difference in a lot of our patients. A lot of people who need these aortic valve replacements are elderly, and not to have to open their chest is a huge, huge accomplishment and progress in how we take care of our patients. The early stage trials are usually conducted in animals, in laboratories, and once they see that it's safe in animals, then they will move on to human subjects. So those are called the phase 3, where we are still enrolling a lot of patients and getting approval from the FDA to get these devices into patients and not just human subjects. So we call them human subjects when they're in an investigational trial. These patients are volunteers, and they know that they're being investigated, and we will be very vigilant about their follow-up so that we know how to take care of these patients. And then phase 4 trials are usually these devices are already approved, and we're looking for other things that we can do with these devices. So phase 3 are the most important trials. Those are usually the big trials that will make or break that device, whether they are going to be approved by the FDA or not. Once we conduct the phase 3 and these trials, the results are collected, they are analyzed by many different people, and then reported to the FDA and made publicly available. And sometimes they are not because they fail to show any evidence of survival, or something went wrong, and so they are not going to be approved by the FDA. And believe me, a lot of money goes into these trials. So next slide, it shows that devices may work differently in women than men. It's really interesting. When we look at data among women and men, we see different differences in who benefits more from these different devices. But WomenHeart advocates for a better understanding of the role of sex that we play in cardiovascular health. We do this by increasing participation of women in clinical trials. And believe me, I've been enrolling patients in trials, and it's harder to enroll women in clinical trials. So please help us by being willing to participate in trials, because we really need to understand women better. We need to have better representation. It's always much harder to enroll women in these trials, unfortunately. If you do participate, you are helping us improve the collecting, analyzing, and reporting of clinical trial data by sex. So we really implore women to help us with these trials. WomenHeart also makes results publicly available and easily accessible to women and their care providers. So WomenHeart is doing their part, and we applaud them for all the things that they do for us. Okay, the next slide is specific devices that we're going to talk about. I'm sure some of you, as Eva told us from the poll, 50% of the listeners have some form of device. So some of you may have a pacemaker. As you can see from this slide, we put the pacemaker under the clavicle. It's going to be under the skin, and we tunnel usually 1 or 2 leads into the vein of the either the left subclavicular vein or the right, but usually if the patient is right-handed, it's actually a lot easier to put it from the left, so most people are right-handed, so this is a good thing. We usually will put 1 electrode in the upper chamber of the heart, of the right atrium, and 1 in the right ventricle, depending on what the patient's arrhythmia is. If the patient has atrial fibrillation, we don't want to put a lead in the atrium, we just want to put a lead in the ventricle. And that's what you see on the C diagram. So a single lead pacemaker should only be put in patients with atrial fibrillation. When we put these electrodes, we put a small electrical impulse into the muscle of the heart, which will then stimulate the heart muscle, and that stimulation will spread throughout the heart chamber, either the atrium or the ventricle. And this works beautifully, and we try to save battery life by using the smallest amount of energy through that pacemaker. And that's why patients who have these devices go to the device clinic, so that we can save battery life, so that you will live with that pacemaker for a much longer time. Okay, the next slide is also about a pacemaker. When you have a pacemaker, you can quickly resume normal activities. You do want to watch out for surroundings for electrical interference, so you want to avoid those those major electrical fields that may interfere with your pacemaker. It's very common to put in pacemakers. A lot of older people will need a pacemaker as their hearts slow down, but it makes people feel so much better when they get their pacemaker, especially if they were living with very slow heart rates for a long time. They feel like they have a new lease in life, and they feel much younger than ever. there are research ongoing right now that are trying to see if they can actually say goodbye to batteries because they have these devices that they're working on that are self-recharging. So I think that's still a few years from now, but we are hopeful that we can save battery life forever and that they won't even need to have battery changes, which is actually a lot easier than putting in a pacemaker initially. But if we can avoid surgery at all, that would be even better. There are some concerns for women because there are women who like to wear sleeveless gowns when they're going to a party, and you don't want the pacemaker to be seen. Men don't really care too much, but a lot of women do care about having a scar under their clavicle. And so for those women, we will ask them if they would like the pacemaker put in under the breast, and that we can do so it's not as seen when they're wearing a sleeveless or a shoulder off-the-shoulder dress. So we've done that for some of our patients, and they're very happy that that's available to them. Okay, moving on to implantable defibrillators. This is called an ICD, or Implantable Cardioverter Defibrillator. The cardioverter means that they can convert the arrhythmia without shocking the patient, and then the defibrillator part is when the arrhythmia gets so bad that they actually have to shock the patient. But an ICD is a device that's surgically inserted, but it is done by an electrophysiologist. We do have to cut the skin, so it is a surgical procedure, but it is done usually by an electrophysiologist. So we insert these devices just like we insert a pacemaker. These devices are a little bit bigger. As you can see in the drawing in B, it's very similar to a pacemaker, but it has a special lead that goes into the right ventricle. And these are lifesavers. We call these lifesavers because when a patient's arrhythmia goes into a life-threatening arrhythmia, these devices can shock the patient or convert the rhythm from a life-threatening one to a normal one. And the main difference between the pacemaker and the ICD is that it not only serves as a pacemaker. All ICDs have pacemakers in them to prevent the very slow heart rates, but it can also treat the life-threatening ventricular tachycardia. Oh, I failed to say pacemakers are devices that treat slow heart rates, and so those are a function that is incorporated into an ICD. The wires with electrodes that end at the end detect the irregularities of the heart rhythm, such as the ventricular tachycardia or ventricular fibrillation, and the ICD can actually pace the patient out of this by giving these a pacing algorithm, but if it doesn't restore the heart rhythm, the device will give a higher level pulse that can be painful in some patients. And so we tell the patients if they feel lightheaded or dizzy, if they feel their device gearing up to shock, that they should lie down. But most patients who have these shocks are actually starting to pass out, so they all of a sudden will get a shock and they will come back to a good rhythm, and they'll just usually a lot of these patients don't remember the shock, but it can be painful. Okay, next slide. So ICDs in women, what does the research say? So there have been a number of large studies recently that have examined how women respond to ICDs. The good news is that when you look at women who fit the criteria for a defibrillator or an ICD, those who get an ICD tend to do better than those who do not. And furthermore, these women may even respond better to ICDs than men. Women who have an ICD implanted seem to have an overall lower mortality than men with ICDs in the first few years after the device is implanted. However, there are special concerns that we should be aware of. Women seem to have a greater risk of complications than men, and these complications, such as infection, may reduce long-term survival. Also, some smaller studies have found that women with ICDs may experience more quality of life problems such as depression, anxiety, worry, and even post-traumatic stress disorder. And these factors do not mean that getting an ICD is not a good idea, but they do not generally outweigh the benefits if your doctor recommends one. So these things are important, and you should be aware of that. We're going to talk in the next slide, Eva, about the multiple stages of an ICD adjustment. So before a patient gets this ICD implanted, they do have some anxiety, they get depressed, they do feel a sense of loss and concerns about their body image. So these can be mitigated by talking in support groups, and that's where WomenHeart support groups really come in so handy. I know some of the listeners some of my patients have these devices, and they're also WomenHeart support group leaders, and I can't thank them enough for helping my patients who have these devices because they do have a lot of these symptoms and concerns, and they have really been a tremendous help for these patients. As time passes, about 6 months later, there is a mixture of anger and relief that can occur, and also denial can also occur. Fear of the device firing, hypervigilance can also be a problem. Sleep disruption, mood changes can be seen in these patients. And this is a period that we call preoccupation with worrying about the defibrillator on a daily basis. But after a while, there is a brief decline in quality of life after this the device is put in. But by year 1, the patient does adjust to normal activities, and there is some adjustment, but hopefully most people do adjust. The next slide is actually 7 tips to adjusting to an ICD. One is defining the problem, so accepting that there is a problem, asking your questions about your concerns about the device, not only with your physician, but with the device clinic nurses. They are a great resource for you. Our nurses here at Rush are just one of the best nurses that we have. They know so much about adjusting your defibrillators and adjusting to your defibrillator. Getting information, very important. It gives you sense of control. Getting team support, like I said, getting other patients to talk or joining a WomenHeart support group. I can't emphasize enough how important that is for you. 4 is normalizing fears. Feeling stressed is normal, but don't let it overcome you. Don't let it get to you so much that you can no longer function. And get help with that if you need it. Emotional release is number 5. Talk about how you feel. There's so much relief when you talk about what your concerns are, especially with your physician, your nurses, and your support group friends. Number 6 is know it is possible to return to normal activities. So the 6-month dip usually returns to normal in 1 year. And then number 7 is take action. Getting back to regular activities builds confidence, and talking routinely helps adjustment. Okay. Cardiac resynchronization therapy is probably one of my most favorite devices because it can not only treat arrhythmia, but it can normalize the heart in somebody who has heart failure. What it does is it actually synchronizes the ventricle when somebody has what we call left bundle branch block or right bundle branch block. When you have this, your ventricles don't beat synchronously. Sometimes the right beats too soon, or the left heart beats too soon, and you have uncoordinated heart function. And this CRT pacemaker coordinates the heart chambers. It's rare that we don't put in a defibrillator with a CRT, but there are some patients there with just CRT. But most of you who have CRT will also have a defibrillator with it. So not only will you get the benefit of the synchronization of the heart, but you will also get the defibrillator and the pacemaker part of the device. So I can't emphasize enough how many of these have really tremendously helped my patients, even patients who have ejection fraction, which is normally 55 to 65%. Some of my patients whose ejection fraction have been as low as 20%, we have been able to normalize their heart function by putting in these devices. So the next slide is actually a picture of how this device looks. You will get a 3 leads. You will have a lead in the atrium, the upper chamber of the heart, and if you have the bundle branch block, you will have 2 leads, one in the right ventricle, and then one that goes through the right atrium and into the vein of the heart, which is called the coronary sinus, which can lead to the left side of the heart, and then through that vein, it will go into the left ventricle. And by coordinating the right ventricle and the left ventricle, it will give a much narrower QRS, which means that the heart is now beating synchronously. And that is a beautiful thing. Okay, next slide. So that slide was actually before. It's not really that clear, but after we put in this device, you may notice that in the EKG part, where there's yellow dots, you can see that the pacemaker is now making what was a prolonged QRS into a narrower QRS, and that by itself resynchronizes the ventricles and makes them beat more synchronously. And that can cure, actually, that can cure heart failure. So if you are suffering from heart failure and your doctor wants you to get a CRT defibrillator, I would encourage you to definitely say yes, because that can actually help you tremendously. I know we're running out of time, so we're going to have to go a little faster, so I've been talking too much. Okay, next slide. Eva, do we have just another 12 minutes or so?
Yeah, it's fine because we started 5 minutes late. So
okay.
we have,
so hopefully,
maybe 10 minutes, and then we can do a 5-minute Q&A. So like 10 minutes.
I'll try to be a little faster.
Fine,
a transcatheter aortic valve replacement or implantation is what we call TAVR or TAVI, which is instead of opening up the chest to replace a heart valve of the aorta, which a lot of elderly people have, we now have an option of going through the artery of the heart and replacing that valve by doing a balloon angioplasty of the valve and then putting in a device that actually have a valve inside of it. So it's like a big stent that you can put in a prosthetic valve inside, and then when they open it up, the stent up, it actually releases this stent that has an aortic valve in it. This is a great option for patients who are old or frail that don't want to have a surgical procedure. It's minimally invasive and it's effective in women. So again, I would recommend having that done if your doctor has suggested that for you. Next is the treatment for for coronary artery disease, and there are many different kinds of stents. And when stents actually were initially made, some of them were just too big for the smaller arteries of women. So unfortunately, women didn't benefit as readily as men did. But now they make them in all sizes and shapes, and there's something called bare metal stents and drug-eluting stents, which tend not to have as much restenosis or blockage, reblockage of the artery. So there are two kinds of stents, and these stents usually are placed into the artery that has a blockage with a balloon angioplasty. And then once the stent is released, they remove the balloon, and that stent actually stays in place. One of the most exciting things about stents right now is the bioabsorbable stent, so that after a few years, you no longer have a metal structure in there, and the artery just absorbs the stent. This is minimally invasive again, so usually we put these in patients who are having a heart attack or patients who continue to have a lot of chest pain on medications and they have severe blockages. Okay, next slide is the two kinds of stent, the bare metal stent, which is the older technology, but again, as I said, it has a greater likelihood of restenosis or blocking again. So these have been replaced mostly by drug-eluting stents. The disadvantage of the drug-eluting stent is that they need the blood thinners, the platelet agents that can lead to bleeding. So in patients who need to undergo surgery right away, we tend to put in the bare metal stent so that they can be taken off after a month of the antiplatelet therapy. So the drug-eluting stents are a newer technology. They gradually emit drugs to prevent restenosis, and these are used mostly over the bare metal stent and also effective in women. Okay, the ventricular, next slide, Eva. This is a complicated slide, but I'm going to try to make it simple. Ventricular assist devices are usually put in patients who have heart failure, severe heart failure. And it used to be just a bridge to transplant, but there are a lot of people who can live with these devices now for a long time. And it may give some patients enough time for the heart to actually recover after a heart attack or some other form of toxins that can cause the heart to fail. These ventricular assist devices can be put in as a bridge to the next therapy. There is a pump unit, as you can see in the picture with a D. That's the pump unit, and we basically bypass the heart so that the heart is no longer what is pumping oxygenated blood from the lungs and into the aorta, which is the blood vessel that the heart uses to pump the blood to the whole body. So it's actually now being used in a lot of centers that do heart transplants, and it's been a great development and progress in our treatment of patients with severe heart failure. Okay, next slide. So what do you need to know? Role of medical devices complement other modes of treatments. Think holistic, so not only are you getting lifestyle changes, being told to help treat your disease, but also medications, but devices can also be part of that treatment. Their treatment trends for women: be aware of disparity in diagnosis and care, and play an active role in managing your condition. And if you are asked by your physician to enroll in a trial, please consider that because we do need more women enrolling in these trials. Okay, next slide. Other concerns for women: there are some women who tend to have scar tissue that are not as sightly as some people. Some women can form keloids, but talk to your dermatologist. They have lotions or medications that can actually decrease the scar tissue. Again, because women tend to wear bras. Some of my patients actually have stopped wearing bras. Good for them. That you can get some irritation from bra straps, purse straps. Make sure that you are not carrying your purse, especially women with heavy purses. Don't carry your purses in that side where you have a device. And also seat belts can also irritate these pacemakers and these devices. Women can ask for sub-mammary implantation, which means it's under the breast, and these incision sites can be less of a nuisance for these women. So don't forget you have that option. And if your electrophysiologist doesn't want you to have that, try to get a second opinion, because there are electrophysiologists that are more amenable to that than others. Okay, next. This is the try to breathe easy slide. There are some relaxation techniques that can help you deal with your stress levels, such as yoga, Tai Chi, meditation, music therapy, and of course exercise. So try to get a buddy to do this with you. It can not only be good for your stress level, it slows down your heart rate, lowers your blood pressure, lowers your breathing rate, reduces the need for oxygen, increases blood flow to major muscles, and reduces muscle tension. So do yoga. Yoga has actually been shown to decrease your incidence of atrial fibrillation. What are your must-ask questions? Some of these are: has this device been tested in women? Were there sufficient number of women in the study to reflect the disease prevalence? Were results significantly, clinically significant? Is this information available? Ask for those from your physicians. Other must-ask questions in the next slide, Eva, are: what are the options for managing my condition, such as the ones that we've talked about already? And if a medical device is recommended, these are the questions you might want to ask. Are there different types of devices available? Are there any devices or surgical approaches that have been shown to particularly benefit women? How will the device affect my quality of life? And those are very, very good questions. And if you don't have these questions answered, you can actually call the device company. They also have people standing by that can answer some of these questions. In case you forget to ask your doctor and you just can't sleep, and there's an 800 number that you can call. And also the last question: what can I do now to prepare myself for successful surgery and recovery, is a good question to ask, and most of the time nurses can answer those questions for you. Okay. Next is the summary slide. I think I'm going to forgo this so that we can answer any questions. So if you want to, Eva, open
yes. Our Q&A.
Yeah, the Q&A, that would be great.
Yes. Well, thank you very much, Dr. Volgman. This was, I learned a lot, too. So we're starting the Q&A. We're going to do about 5 minutes. First, I want to thank our sponsor of tonight's webinar, Boston Scientific. And now instructions for submitting your questions. You will type your questions in the question box on your control panel and click Submit or Enter. And your question will appear on my control panel, and I will read the questions in the order in which I received them, and Dr. Volgman will answer. So again, you would just type it in your control panel and hit Enter. Okay, I see we already have several questions.
Wow.
That's
Okay,
a
somehow
good sign.
I've lost, I think I'm still on, but let me know if
You
there's
are.
a problem.
Yeah.
Okay, good.
No. Everything's fine.
Okay.
So,
I see, I'm back now. Okay.
Good. Yeah, you were, I don't think, yeah. Okay, here's a question
Okay.
from Stephanie. Any thoughts on heart stem cell research ever being approved in the U.S.? And how much would it
Absolutely.
increase our ejection fraction if it were
Yes.
approved?
Yes. Stem cell research is strong and alive in the United States and in the world. Actually, here at Rush, we have a physician who is working on stem cells to replace heart valves. So especially for pediatric patients, because they need to grow with the patient. If we just put in these mechanical heart valves, they don't grow with the patients and they need to be reoperated. They're working on resorbable struts for these valves that their stem cells of the patients will grow over it and become the heart valve for these patients, and so they don't need to be reoperated on. There are stem cell research going on for heart failure and for coronary artery disease as well. So stay tuned. That is going to be in the future.
Thank you. A question from Joanne. I currently have a Boston Scientific ICD. Is it possible for me to participate in a Pilates class?
I'm sorry, say that again?
She has an ICD. Is it possible for her to participate in a Pilates class?
Absolutely, of course. You will have a period when you should not put your arms above your head for pacemakers and for the ICDs and CRT devices. For about 3 months, you should not put your arms above your head so that the leads can grow and cause a scar tissue in the heart so that it will not be easy to dislodge the lead. So when your cardiologist tells you that it's okay to put your arms above your head, that's when I would recommend that you do the Pilates. But in the meantime, there's no reason for you not to walk as an exercise once you have these devices put in.
Great. Question from Joanne. How long does the battery last in a pacemaker?
That is a good question, and that question has many, many different answers. If you need your pacemaker to pace your heart 24/7, you will probably need a pacemaker in as little as 5 to 7 years. But if you need your pacemaker only intermittently, once in a blue moon, you could have that pacemaker for a much, much longer time, as long as 20 years even. So it really depends on how much you use it. And that's why you need to go to the pacer or device clinic to have your pacemaker and device checked so that they are giving you the best possible charge that you need for the device to work. They can adjust how much charge the device needs to pace your heart so that you can save battery life.
Okay. A question from Catherine. What is the difference between an ICD and a CRT?
So the ICD is a shock, so it has a pacemaker, it has a cardioverter, which can pace people out of a ventricular arrhythmia, and it can also shock your heart. But the CRT can do all of that, but you need an extra lead to synchronize the ventricles. These are put in patients who have heart failure and whose EKG looks for the QRS. There's a portion of the QRS or a portion of the EKG that is prolonged, such as in patients with left bundle branch block. Those are the patients who mostly benefit from these devices, the CRT, or if you have a right bundle branch block. But the QRS usually should be at least 120 milliseconds for them to benefit from it.
Okay.
I hope that answers the question.
Yeah, I think it did. But okay, so a question from Christine. She has been on Plavix for 2 years, or she had been on Plavix for 2 years after having 3 stents put in, and she wonders if there is a time where you can get off Plavix when you still have stents.
Yes. Most people just need the Plavix for a year unless they have ongoing chest pains and the physician wants them to be on a stronger antiplatelet drug. Most patients will just need it for a year, but I see a lot of patients benefiting from it for 2 years, but after 2 years, we usually will take the patients off the Plavix unless they're having continued chest pains.
Okay. Question from Marcia. How long does a drug-eluting stent elute the drug?
That is a good question. Usually it takes months for it to be completely eluted so that it can be ongoing for a long time. But that's why we still want them to be taking statins, beta blockers, and aspirin and the Plavix to make sure that there is no plaque building up on those coronary stents. And for patients with coronary stents, we need them to be on the strongest statin available. Even though we're not looking at targets as much as we used to, we do want those LDL cholesterol to be less than 70 in patients with stents.
Okay. We're just going to take 1 or 2 more.
Okay.
Just so 2 more. Eve is asking, she has an ICD, and she prefers to be patted down at airports and government buildings rather than going through the x-ray machine. She's wondering if she's overreacting in that regard.
Oh, no, not at all. You're not allowed. You're not supposed to go through those screenings because it would actually set it off. So you're not overreacting. That's what you should have been told to do in the first place. So no,
okay.
that's the right thing to do. And for all of you listening who have devices, that's what you should be doing. You should be patted down.
Okay,
and you shouldn't
great.
have the wand over the pacemaker or device because it can actually not set it off, but it can actually change the setting of your device. So don't let them put a wand over your device.
Okay, wonderful.
Thanks for asking that, actually.
That's interesting, yeah. And we're just going to take 1 more from Cynthia. She has a Boston Scientific LCD, and
you mean ICD?
She always ICD, sorry. And she always has difficulty. She feels that a feeling of heaviness in her breast, in her chest, and is wondering if there's any research or any way around this.
From my patients who have this problem, they do need to wear a more supportive bra. Like the sports bras are better because it puts the defibrillator closer to the body so that it doesn't feel like it's being supported by the body. So I would recommend talking to some of the other women in the support group, or just talking to the device company and seeing what they would recommend to help them not have the sensation. Probably a good bra or good support for the skin would be better.
Great. Thank you so much, Dr. Volgman, and thank you for this great presentation and for answering all the questions. We're probably going to close because we're running a little bit over. But again, thank you so much for your expertise tonight, and for everyone who is on with us. Thanks for attending. Tomorrow, you will all receive an email from GoToWebinar that will have the the link to the YouTube recording of this webinar, so you can watch it again at your leisure. And finally, just thank you to our sponsor who made tonight's webinar possible, Boston Scientific. Dr. Volgman, do you have any parting words?
Yes, Eva, thank you for allowing me to participate in this. And I think that for the next webinar, if we're going to do this, I think we should actually use some of these questions as some slides, because they were very, very important questions that we need to go over with some of these patients. So I thank you so much for the people who asked these questions, and I want to thank everyone who actually participated in this webinar. And thank you, Eva and Lisa and Emily. Thank you.
Thank you so much. So this concludes our webinar, and we will take your advice for the next one. I'm going to compile the questions. Thanks again, and good night, everyone.
Good night.
Good night.